We're very excited to bring to you today a discussion about a group of sarcoidosis cases that have presented to OHCOW as a part of our McIntyre Powder Exposed Mine Worker cluster investigations. OHCOW started investigating the potential health effects from McIntyre powder exposure in 2016, and we now have registered over 600 mine workers. McIntyre powder is an ultrafine aluminum powder that was used to prevent silicosis in Ontario mines between 1943 and 1979. It was thought at that time that inhaled aluminum would decrease the solubility of silica particulates in the lung and mitigate its effects and prevent silicosis. OHCOW's focus from the beginning of this project has not only been to understand better the effects from McIntyre powder itself, but the whole of the mining industry in Ontario. I would now like to welcome our speakers, Dr. Christine Oliver and Paul Sampara. Dr. Oliver is a medical consultant to OHCOW who is board certified in internal medicine and in occupational medicine. She is currently an adjunct professor in the Division of Occupational and Environmental Health at the Dalla Lana School of Public Health. She formerly had a clinical practice at the Massachusetts General Hospital in Boston and was an associate professor at Harvard Medical School. Her area of interest and expertise is occupational lung disease. Since she began work here at OHCOW in early 2018, her focus has been on miners in Northern Ontario, generally on the cluster of miners exposed to McIntyre powder. Paul Sampara has worked in occupational health and safety since 1978. He has been back with OHCOW as an occupational hygienist for the last 5 years, working on projects such as the sarcoidosis case series that we're presenting here today. He previously worked for 10 years as an occupational hygienist at the OHCOW Hamilton Clinic. And in between these stints at OHCOW, he worked at the WSIB for 15 years as an occupational hygienist, doing individual exposure assessments for occupational disease claims, and as a scientist in the Occupational Disease Policy and Research Branch. So I'm very honored to have both Dr. Christine Oliver and Paul Sampara here today. Janice, could you pass it to the next slide, please? Before I pass it off to Dr. Oliver, I'd like to point out that all the findings presented here today can also be found in the April 2022 issue of the American Journal of Industrial Medicine, and we'll provide the link to this open access journal article in the chat. I would now like to pass it off to Dr. Christine Oliver, and thank you all for being here.
Good morning. Thank you very much for coming to our discussion this morning. As Andrew indicated, I am a physician and I will be approaching the discussion this morning from the perspective of an occupational medicine physician with an interest and specialty in occupational lung disease. Janice, if I could have the next slide, please. Our objectives this morning are to define sarcoidosis and to review criteria for the diagnosis, to consider the validity of the current definition of sarcoidosis, which includes idiopathic, to present the rationale for our case series of sarcoidosis in Northern Ontario hard rock miners, to discuss occupational exposure assessment that was done as part of our project, to present our findings, and then finally to examine the implications of our findings for the long and short-term health of miners. Janice, if I could have the next slide, please. Sarcoidosis is defined as a multi-system granulomatous disease of unknown cause. Let's unpack this and look at the key components of the definition. First of all, multi-system, which means that more than one organ system in the body is potentially involved. Not always, but can be. Granulomatous, what does that mean? Histopathology shows granulomatous inflammation in the case of sarcoidosis. And what this means is that the organs involved are infiltrated, if you will, with small nodular lesions, which have a characteristic appearance under the microscope. unknown cause. That means that sarcoidosis is considered to be what is called an idiopathic disease. Next slide, Janice. Janice. Diagnostic criteria, sorry. So the diagnostic criteria are first a compatible clinical presentation. The clinical presentation of sarcoidosis is variable. What often happens is that a chest x-ray is obtained incidentally for some other reason. And what is found is enlargement of lymph nodes in the central portion of the chest. These are called hilar and mediastinal lymph nodes without other apparent cause. Secondly, non-necrotizing granulomas in one or more tissue samples. And then thirdly, the exclusion of alternative causes of granulomatous disease. The diagnosis of sarcoidosis is not standardized. Next slide, please. Is sarcoidosis a disease of unknown cause? One of the questions that we will be discussing here is it a disease of unknown cause? When sarcoidosis was originally described in 1898, 1899, it was justifiably a disease of unknown cause. For the ensuing several decades, it was justifiable, valid to call it a disease of unknown cause. What we want to do here is examine whether that is still the case. Sarcoidosis has been associated with occupational exposure to inorganic dust, specifically silica, metal dust, and World Trade Center dust. Sarcoidosis has been associated with occupational exposure to fungi, fungal dust, dust from other microbes, and also musty odors. Sarcoidosis has been associated with certain occupations and industries. Some of them are shown on this slide, specifically construction, firefighting, foundry work, mining, metal work, and agriculture work. Next slide, please. A number of case reports have been reports of sarcoidosis in individuals who are occupationally exposed to silica. Silica is one of the most frequently and consistently found occupational exposures that are associated with sarcoidosis. Several case reports are shown on this slide. The first is our report of sarcoidosis in hard rock miners published last year. Mokizuka reported a case of sarcoidosis in a plasterer exposed to silica in Japan. Ronsman et al. Reported 2 cases of sarcoidosis in metal halide lamp production workers in Belgium. In the Netherlands, Bezier et al. Reported a case of sarcoidosis in a plasterer who was exposed to silica and was misdiagnosed initially as a case of silicosis. Ozemezoglu reported 4 cases of sarcoidosis in iron and steel industry workers in Turkey. Kawano and Dorado in 2012 reported a case of sarcoidosis in a tunnel worker exposed to silica in Brazil. Next slide, please. Associations between sarcoidosis and silica have been shown in epidemiologic studies, both case control studies and also cohort studies. Graf et al. Reported sarcoidosis in Swedish construction workers. The ACCESS study, which is a case control etiologic study of sarcoidosis, was reported based on data collected in the United States. Rafnesson et al. In 1998 reported sarcoidosis in diatomaceous earth workers exposed to silica in Iceland. This was one of the first epidemiologic studies showing associations between sarcoidosis and silica exposure. Johnson et al. Reported occurrence of sarcoidosis in a cohort of Swedish construction workers. Vilborg reported associations between sarcoidosis and silica exposure in Swedish iron industry workers. Next slide, please. The origin of our case series lies in a cohort of Ontario hard rock miners exposed to McIntyre powder. As of May 2021, the number of members of that cohort was 506. A McIntyre Powder Project mandated file review carried out by the OHCOW team revealed 17 members of the cohort who answered yes to "Have you ever been diagnosed with sarcoidosis, sarcoid-like disease, or granuloma, and or had a diagnosis of sarcoidosis in their medical record?" Next slide, please. The rationale: sarcoidosis is a rare disease. The significance of 17 potential cases of sarcoidosis in 506 miners was unclear at the time, but an important occupational exposure for these miners was respirable crystalline silica. Published case reports and published epidemiologic studies showed associations between respirable crystalline silica and sarcoidosis. And what I neglected to mention on the last slide, of these studies cited, both the case control and also the cohort studies, each of those studies showed associations that were statistically significant between sarcoidosis and silica, with one exception, and that was the access study. They found significant associations between sarcoidosis and other occupational exposures, but not silica. Having observed 17 potential cases of sarcoidosis, even though we weren't sure of the significance of our findings, we felt that it was important to further investigate what we found because of their occupational exposure and because of what had been reported in the literature. Next slide, please. We categorized our cases into 4 groups. The first was definite sarcoidosis. There were 8 workers in that category. Probable sarcoidosis, 4 members of the cohort in that category. Possible sarcoidosis and sarcoidosis unlikely. Definition of definite sarcoidosis case was having answered yes to the screening question and or having had a diagnosis of sarcoidosis in the medical record and satisfying the diagnostic criteria that we reviewed earlier. A probable case was defined as meeting criteria for a definite case. However, in probable cases, we did not find in the medical record a pathology report confirming the diagnosis of sarcoidosis. So for that reason, we categorized those individuals as probable. A possible case was a case in which their treating physician had made a diagnosis of sarcoidosis, but when we reviewed the record, the medical record, the file of that person, we were unable to confirm the diagnosis. So we categorized those individuals as possible. Unlikely were minors for whom we found an alternative diagnosis in the medical record. Next slide, please. The mean age of our group of 12 cases, so we focused on the 12 potential cases that were categorized as definite or probable. The mean age of that group was 74 with a range of 65 to 88. All were male, all were white. Most were ex-smokers or current smokers. 16.7% were never smokers. Organ systems involved in our group reflected the organ systems involved in the general population. Mediastinal and hilar lymph nodes were involved in 92% of our cases. The lung tissue itself was involved in 42%, 5 individuals. and extrapulmonary involvement was found in 5 individuals, or 42%. Of the 5 with extrapulmonary involvement, that means outside the thoracic cavity. The lungs were not involved, and the mediastinal and hilar lymph nodes were not involved. Of the 5, 3 were cases of endocrine sarcoid, and 2 were cases of cardiac sarcoid. Next slide, please. Information about occupational exposure to respirable crystalline silica in our series was derived from a detailed work history that in turn was derived from a questionnaire and personal interview, where personal interview was thought to be helpful. Air sampling data sources provided information about their silica exposures, and the principal source of air sampling data was the Ontario Mining Exposure Database, or OMED, which Paul Sampara will describe in some detail. It's a little beyond my pay grade. I think it's important, however, to note that the air sampling data, while the miners themselves did not walk around in the mines with personal air samplers on their person, the data that were assessed by Paul for our series were derived from the same mines that our miners worked in, and during the same time period that they worked there. So it's the next best thing, in my view, from having personal samplers hung on the miners and using those data. The duration of exposure was close to 20 years, a wide range of exposures, a wide range of duration from 6 to 28.5 years, latency average close to 30 years, again with a wide range. Next slide, please. The fundamental data applying to the 12 cases is shown on this slide. The mean annual exposure for the group as a whole was 0.14 milligrams per meter cubed. The mean cumulative exposure, that means how much silica exposure did they have over the entire period of their work as a miner in Ontario, was 1.93 milligrams per meter cubed years. Vilborg et al. In their study of workers in the iron foundries observed a close to 4-fold increase in incidence of sarcoidosis in those who, in the group that had mean annual exposures greater than or equal to 0.048 milligrams per meter cubed. So our finding of mean annual exposures in our group of 0.14 milligrams per meter cubed is 3-fold higher than the lowest dose observed by Vilborg et al. To be associated with a statistically significant increase in incidence of sarcoidosis. The two are not comparable because they conducted a cohort study. We had a group of 12 exposed miners, but nevertheless, I think it's worthy of note. In our group, gold mining was the most common type of mining. Elevated respirable crystalline silica exposure was observed not only in underground mining, but also in surface mining. Next slide, please. What are the implications of our findings for the short-term health of workers? Our case series, as far as we know, is the first published report of sarcoidosis in hard rock miners. The consistency of our association between sarcoidosis and respirable crystalline silica exposure adds to the existing body of knowledge and raises questions about an increased risk for sarcoidosis in hard rock miners. We hope that a short-term implication of our findings is that awareness of this association for healthcare providers will be increased. Healthcare providers who have patients with sarcoidosis should obtain a detailed occupational history. In some cases, removal from exposure may be indicated if the healthcare provider has reason to suspect there's an association. In some cases, the healthcare provider may be called upon to support their patients file for workers' compensation as a remedy. Next slide, please. Long-term implications. Other miners exposed to respirable crystalline silica may be at increased risk for sarcoidosis. An example is coal miners. Is sarcoidosis another coal mine dust lung disease? We'll see. We don't know right now. Maybe. Are there implications for diagnostic testing? There may well be. There are researchers in the Netherlands and other parts of the European Union who are examining the potential role of lymphocyte proliferation testing in individuals with sarcoidosis, looking for sensitivity to silica and certain metals. This is a diagnostic test that has proven critically valuable with chronic beryllium disease. And then finally, is the term idiopathic in reference to sarcoidosis past its prime? Is it time to move beyond that in terms of considering causation with sarcoidosis? Next slide, please. So to conclude, case reports in increasing numbers suggest an association between sarcoidosis and respirable crystalline silica exposure. Statistically significant associations have been observed in epidemiologic studies examining this association. While these published reports do not prove causation, they do inform our assessment of the relationship between sarcoidosis and respirable crystalline silica and provide basis for eliminating idiopathic as an ever-present adjective. In some cases, a cause cannot be identified, and in those cases, application of the term idiopathic is appropriate. In other cases, occupational exposures or other exposures can be identified that require further investigation. In those cases, the application of the term idiopathic is not appropriate. We should err on the side of caution in order to enable prevention, both primary prevention and secondary prevention. Next slide, please. In our case series, in our published report, we address the issue of McIntyre powder. The contribution of McIntyre powder, if any, warrants further investigation. And this is being carried out currently in collaboration with the OCRC here in Ontario. The final two slides contain references that were relied upon in our case series and were used in putting together my presentation today. So at this point, I will turn the mic over to Paul Sampara, and he will discuss the occupational exposure assessment for our 12 cases. Thank you.
Yes, thanks, Chris, and good morning, everyone. So I wanted to describe in a little bit of detail some of the background and some of the issues and challenges with exposure assessment, not only for this case series, but anytime we're looking at historical exposures among miners, we have this ongoing challenge. So like Chris said, the two main exposures that we considered for this case series was respirable crystalline silica, as she indicated in some of these studies, have been associated with sarcoidosis, and McIntyre aluminum powder. So those are the two main exposures we were looking at. So just a quick overview of the cases, 8 definite cases, the types of mining, again, and I think Chris already mentioned, gold was the most common. So all of them had some gold mining experience or exposures. And as with most miners, like miners don't sort of just stay in one mine or one type of mining for their lives. It's rare. They typically move around from mine to mine. So two of the 8 had exposures in uranium mines. And then sort of just the general category of base metals, 5 of them had worked in nickel, copper, or zinc mining as well. So then you can see in the last line, the total mining average exposure was about almost 22 years, with again a fairly wide range from 6 to 28.5. And the work period ranged from 1951 to 1999. And you'll see as I go along here, that's part of the challenge, is to sort of come up with or estimate that historical exposure. Next slide, please. So the historical sampling in Ontario gold mines, it started out in the late 50s to the late 70s, early 80s as counting particles. Basically, an instrument called a conimeter was used. It's sort of just an instrument that takes literally a 1 second sample. You just sort of hold it out and click the little piston, and it collects a sample of air that whatever the particles are goes onto a microscope slide. And then the particles, literally the number of particles are just counted under a microscope. Because back in the early days, the thought was it was the amount that the number of particles that you inhaled that was important for health effects. So they would use the conimeters, and they're instantaneous, obviously, if they're just doing a 1 second sample, and it's total dust. And it was originally done, well, not originally, but always done to more or less check the effectiveness of ventilation and other exposure controls. And as Chris said, this is way before personal sampling days. So it wasn't necessarily a direct measure of personal exposures, but they did take some of the samples during specific activities like drilling and mucking and that kind of stuff. So even though it's not entirely representative of our personal sample, it's really the only data we have for this period of time. And then when we get to the early 80s to the present, size selective gravimetric sampling came into use, because the realization was that it's not the number of particles, it's the mass of particles per volume of air. So milligrams per cubic meter, and you've probably seen that fairly often when people talk about air sampling and that sort of thing. So it only collects, when it says size selective, it means it only collects the respirable portion of the dust. And then it's expressed as milligrams per cubic meter. So the big challenge that we have and continue to have is estimating things like respirable dust and crystalline silica exposure prior to the gravimetric sampling of the early 80s. So in other words, converting the particle counts, the ppcc's, particles per cubic centimeter, into milligrams per cubic meter. And one important step that was done in the early 80s, there was a large epidemiological study of silicosis in Ontario hard rock miners, and Dave Verma, and anybody that knows anything about occupational hygiene knows that he was, a very important figure in the field of occupational hygiene, not only in Ontario, but internationally. But anyway, so what he decided to do, because up until that time, there were theoretical proposals, there was some suggested, conversion formulas. And in particular, if you look at the literature for the South African gold mines, people were publishing different steps involved in how do you get from ppcc to milligrams per cubic meter. And so there wasn't really a clear or agreed to approach to that. So what Dave Verma did was, as part of that study, was to actually do side-by-side sampling. So in other words, they rustled up some historic conimeters and then the modern day gravimetric samplers, and literally sampled miners doing different activities to come up with some sort of conversion formula, which then ended up being a table to do this direct comparison or this conversion. Next slide, please. Yeah, if you can click again, maybe. One more. One more. There we go. Okay, so the Burma paper came up with this table. So on the one column you had respirable silica in milligrams per cubic meter, and then the equivalent conimeter counts, the particle counts in gold and uranium mines. Now, a very important consideration is that this is not a linear relationship. It's not a one-to-one kind of conversion. You know, he came up with this fairly somewhat complicated equation that has linear aspects to it, but also exponential functions, which is, oh, go back there. So in other words, it wasn't a linear relationship, and an important aspect of that was that a very small increase in the particle counts could result in a very significant increase in the respirable silica. So I've circled a couple of examples there. So a small increase you can see there for gold mines of only 18 particles per cubic centimeter, or 4% increase, would translate into a doubling of the crystalline silica exposure from 0.2 to 0.3. So that's part of the problem, is that you know, we only have this general data on particle counts, but then it becomes very critical when you do the conversion to crystalline silica, that small increases or decrease can make a big difference. And the same thing for the uranium mines as well. So next slide, please. So that's sort of one aspect of this whole issue of, you know, dealing with this converting from particle counts to gravimetric, and then actual sources of data. So in 1976, those of us that have been around long enough to remember, there was a HAM Commission, or the Royal Commission on Health and Safety of Workers in Mines. It was a very important report because it actually set the stage for a lot of health and safety legislation that came from that, including the you know, the Act and all of that, all the regulations that came from that. So in their report, they used or reported the average conimeter counts, or average particle counts, that were reported in the semi-annual MAPAO reports, the Mines Accident Prevention Association of Ontario, from 1958 to 1975, because what the MAPO did was they sent out forms to all the mines, and then the mines, the mining engineers, would do sampling semi-annually, so a couple of times a year, and in some cases, you know, 3 times a year, 4 times a year, and then record their measurements on these forms, and you'll see an example in a second, and then send that to the MAPAO, and then they would in turn average all those counts together to come up with a sort of a range or an idea of what the exposures were in the mines. And so that then the mines could compare themselves to each other. So if I was operating a gold mine, I could see what all the gold mining industry was doing and how I compare. And also those results that were reported to the Ministry of Labor and to the Workers' Compensation Board. And then 2 individual surveys that were done, one in 1974 by the Ministry of Health in Ontario, was specifically for a couple of uranium mines, Rio, Algoma, and Denison, where they gathered, and again, here's Dave Verman name popping up again. They did a survey, no, that's not a survey, sorry. They looked at all those results of about 1,000 dust samples that were collected, and then sort of summarized this information for total dust and respirable dust, because and then they published a paper based from that fairly recently in 2014 and 2015, because this survey, those results weren't really available or readily known until, like I say, 2015, 2014. And the same thing with the gold mining survey that was done by the Ontario Ministry of Labor in 1979. It was a smaller number of samples, 277 respirable dust and silica samples at gold mines. but when you look at that survey, or you look at the summary paper by Verma in 2014, he was really kind of comparing different, because at that time, as I say, there was this transition from particle counting to gravimetric sampling. So they were trying out different gravimetric sampling instruments to see, to kind of come up with, okay, what's the best one that we can use, you know, for going forward for respirable dust and silica sampling. Next slide, please. So here, just very quickly, so from the Ham report of the Royal Commission on Ontario mine workers. So this is the sort of thing that they reported. So so that just comparing overall, and again, this is like everything lumped together for all the mines, you know, to say, okay, where were we in 1960 and compared to 1975? So at the time, if you look on the right side, MAPAO, because again, this is before kind of formalized regulations or exposure limits by the Ministry of Labor, they had come up with sort of guidelines for the industry for nickel, gold, and uranium, you know, recommending that try to keep the exposures below 500 particles per cubic centimeter, or 300 and 200 respectively. And then that was used as sort of a yardstick, or to measure what those semi-annual report, no, go back. What the semi-annual reports were coming up with. So, you know, if you look at up to the first half of 1960, you know, like all the averages for nickel, gold, and uranium were above the MAPAO guidelines. So, you know, not that great. Obviously, they weren't controlling the dust all that well. And then by the first half of 1975, the averages are showing, you know, just above or close to or below the various guidelines. So, you know, the industry patted themselves on the back and said, okay, yeah, we're doing a really good job here. We've cut everything down. Everything's fine. So next slide, please. Yeah, you have to click a couple more times. One more. Okay, there we go. Oh, one too many. There we go. So I just wanted to show you an example of one of these semi-annual reports, to give you sort of an idea of sort of, you know, where the data started from, and then how it ended up being averaged into these overall kind of numbers that then became sort of the accepted, or the sort of the accepted sort of exposure levels for the different mines. So here's one here. So you can see, and it's a little hard to read, but on the left side of their operation, there's a whole variety of different things, you know, dumping, drilling, crushing, and then they would take samples, and they would have take a number of samples and then average those. But then they would report at the bottom, you can see in the red box there, sort of the overall average for all those different operations. But interestingly, they did break down to show how many samples were in different ranges. So if you look at the box on the right side, so even though the overall average was 328, the range was anywhere from 95 to 525. Almost half the samples were above 300 particles per cubic centimeter, which was the MAPAO guideline for gold mines. 20% were above 500, which even to this day, WSIB uses it as a definition of quote unquote dusty gold mining when they do their adjudication of lung cancer in gold mines. And then 6% were like way above 800, which is considered the upper limit of conimeter measurement. So it just gives you an idea. I guess the point I'm trying to make here is, yeah, you can take these averages, and the average might look, you know, okay or reasonable, but when you actually start to look at the detailed data, it tells you a different story altogether. And again, so this is one semi-annual report for one mine. So you can imagine, you know, all these reports being gathered and then averages of averages of averages being calculated. So it's not really giving you a true story of what's going on. So next slide, please. So, um, I tried to give you a picture of not only the challenge of the conversion from particle counts to gravimetric, but also the issue of, you know, how, you know, how the data is used and you know, what the sources of some of that data is. So what happened a few years ago is the OCRC, Occupational Cancer Research Center in Ontario, gathered together, and they were literally like bankers' boxes full of paper records of semi-annual reports of MAPAO, Ministry of Labor sampling reports, you know, for the different years, and even reports from the individual mining companies. But it was by no means you know, 100% complete. In other words, they didn't have every single one of the MAPAO reports, but they had a good chunk of them. So as I've indicated here, so there's about 120,000-ish sampling records from all these sources. As you would expect, most of them are for dust, silica and radon. And so there's roughly over 1,000 records for each year from about 1970 to 1991. Now there are records for other years, you know, as I said, going back to the 50s, but they're fewer, a smaller number of records. And in total is about 4,200 crystalline silica measurements for the different mines, gold, uranium, nickel. So what OCRC did was take all these boxes and boxes of paper records and enter them into a kind of an Excel spreadsheet. And as you can imagine, that, you know, you've got different formats, different sort of ways that, you know, if you compare the Ministry of Labor reports to the semi-annual reports, some of it was duplication. It was sort of not a really clean set of data. But at least it was collected into one source, and they called it the Ontario Mining Exposure Database, or OMED. Now, I have to point out a big shout out to Martin Albinger, another occupational hygienist at OHCOW. He took that Excel spreadsheet basically and developed it quite a bit further, you know, for us to be able to, you know, use all that data in a more constructive way and make it more searchable. So we can look at that data by type of mine, type of contaminant, the task, location, and all that sort of thing. So if you can have the next slide, please. And I know this is hard to read, but this is sort of just a screenshot, just to give you just a very general idea of what I mean. So, you know, you can enter like what it is that you're looking for, like dust, you know, the type, if you know the name of the mine, like this one is for Denison, you can pull up that specific data. If you want to look at all gold mining or all uranium mining, you can do that. You can look at it by type of activity or the process or the task. And by year, you can see kind of towards the right, you can see a block of data here from 58. Yeah, like for 1958. And then it'll give you the average and the range for that data over that year. And so you can do that sort of by year, you know, by, you know, type of mine and that sort of thing. So you can dice it and slice it a lot of different ways, which makes it obviously a lot more useful than either having boxes of paper records or just sort of an overall spreadsheet. And along the bottom, and again, this is of interest only to hygienists probably, you know, Martin's built in some really useful ways of sort of, you know, trying to do some statistical analysis of some of this information. So next slide, please. I just wanted to give you just a quick idea of what it looked like. So the a long lead up to this whole thing is that OCRC's OMED, the occupational, the Ontario Mining Database, was the source that we used to come up with crystalline silica estimates for this case series. So like I say, a bit of a long-winded buildup, but I wanted you to appreciate some of the history of what that data is, where it comes from, and what some of the challenges are in using it. So the total duration of crystalline silica exposure, the mean was about 22 years and the range was from 6 to 28. This is for the 8 definite cases. And the annual or the average crystalline silica exposure was 0.16. Keeping in mind that the current exposure limit is 0.1 and the range from 0.06 to 0.29. So, quite a big range. And then the cumulative exposure, which as Chris explained is the average exposure times the number of years. So the mean was 2.32 milligram per cubic meter years, with again a fairly wide range of from 1 to 4 milligrams per cubic meter years, and this is all based on OMED data. And I have to say just very quickly is, as much as possible, we try to, like for a specific miner, we had a very detailed work history, so we would try to get data for that specific mine, for that time period, and for that activity. So let's say he was a driller from 1958 to 1964 at mine X. So we would go into OMED and look for that specific data. If it was there, great. If not, then we would have to sort of, back it up and say, okay, well, we don't have anything for that particular gold mine, but we can look at like all gold mines together. So then we would use that data. So as I say, we try to, as much as possible, be specific to the miner's work history, but in other cases we would have to make some assumptions. And again, as I've said, the data in OMED is not 100% complete. It's not like we have everything from the early 50s to the late 70s or early 80s. There are gaps, so you have to sort of make some assumptions about the data in between. Next slide, please. So this is for all the cases together. So the total years of exposure to residual crystalline silica was about 19 years with a range of 6 to 28. And the average exposure was 0.14 with a range of 0.06 to 1.13. And as I've indicated by the asterisks, it's compared to the current Ministry of Labor, well, I still say Ministry of Labor, but they keep adding more and more alphabet soup to their name. But anyway, MLITSD, I can't even say it anymore. The exposure limit is 0.1. And then the proposed exposure limit is 0.05. So you can kind of compare what the mean exposures were. And then the cumulative exposures ranged, again, quite a wide range from 0.64 to 4, with a mean of about 2 milligrams per cubic meter years for all the cases together. So next slide, please. Yeah, keep going. Okay, good. So I wanted to put this slide in here because, not too long ago, just in June 2021, OCRC themselves did a bit of an analysis of OMED, looking specifically at crystalline silica measurements between 71 and 91. And they found that the arithmetic mean, the average for the gold mines was 0.1. This is very similar to what Verma came up with from his analysis of the one survey of gold mines. And one of their findings was the probability of overexposure to RCS remained high in the Ontario mining industry. So even though exposures tended to decrease over the years, they concluded that the probability of overexposure remained high. And another important finding, and I think Chris mentioned this too, is that the general assumption is that surface miners are exposed to much lower concentrations because they're not in as confined an area as underground and so on. But really, go back. But really, when you look at the data, there isn't much difference between the exposures of underground and surface miners. So that's an important thing to keep in mind, that you can't always assume that the surface miners were exposed to much less. Next slide. Actually, no, sorry, go back again. Yeah, so I also put this slide in here because it kind of gives us some confidence in kind of our estimates, because OCRC looked at the RCS exposures between 71 and 91 and sort of said the mean concentration was 0.1, and our calculation for the mean exposure for the whole case series was 0.14. Now, it's I think it's reasonable that it was higher because, as I said, you know, some of those miners had work histories going back to the 50s. So, and it's well known that the exposures were much higher in the 50s and 60s and going into the 70s. So for us to come up with an overall estimate of 0.14 isn't too, we're in the ballpark. It's not too far off from this, and also similar to you know, Burma's analysis of that one survey. So you know, I have good confidence in our estimates. Next slide. And as Chris said, we also looked at McIntyre powder for this case series. And for the 8 definite cases, they had an average of about 5 years and anywhere ranging from 3 to 10 years. And then based on the time-weighted average exposure of 0.74 milligrams per cubic meter, which is actually the estimate that WSIB themselves came up with, you know, based on, the McIntyre powder was, the miners were, you know, in a room before they would start their shift, and you know, they closed the doors and everything else, and they pumped in the aluminum powder, and there was they knew the amount of powder that went in there, and you know, based on the size of the rooms and so on. Anyway, the long and short of it is they were able to come up with an estimate of saying, okay, if we have this much powder in this volume size room, and then based on an 8-hour, if they were exposed for 8 hours, it would be equivalent to 0.74. So then using that figure, then the cumulative McIntyre powder exposures could be calculated or estimated. And so that came out to about 4 milligrams per cubic meter years, with a range of 2.4 to 7.6. And as Chris said, at this point, we don't really know what the role is, or possible role is, for McIntyre powder as it's associated to sarcoidosis, if it is or it isn't. So that's still something to consider, but at least we have some estimates of exposure. Next slide. Yeah, and then this is just for all the cases together, so very similar kind of estimates. The mean was about 4.2 milligrams per cubic meter years, and a range of 1.8 to 9. And again, this gives us sort of, you know, some good estimates for McIntyre aluminum powder, and this is being further kind of pursued or investigated to see how it might be associated with sarcoidosis. Next slide. Okay, I'll turn it back over to Andrew to do a little wrap up.
Great. Thanks, Dr. Oliver and Paul, for the great talks. I'd just like to thank the remaining members or authors on the publication. specifically Janice Martell, the founder of the McIntyre Powder Project, as well as our occupational health nurse, Donna Pearson, who tirelessly conducted health history interviews with all the workers, as well as compiling and summarizing clinical and medical records so that we could do this work. Also, the invaluable assistance from the whole of OCOW. This was truly an organization-wide project, but specifically Brittany Ramaco and Cheryl Baker for following up with doctors' offices, getting medical records and WSIB claim files, and compiling all of the documentation needed to do this level of work. And as well as Paul mentioned, Martin Albinger for his database expertise in wrangling all of the OMED data so that we can use it in a constructive way. And finally, but not last, Dave Wilkin, who from the beginning has been leading out all of OCOW's cluster investigation work. And of course, the miners themselves and their families for trusting us with this information so that we can have as much of an impact with it as we can. And I'd love to thank everybody for coming today. And as I mentioned before at the beginning, I did place the link to the open access article that you can access and review. And I'd love to open it up. We've got maybe 1 minute for some questions. You can throw them in the chat or you could unmute yourself. And we'd love to take any questions. We'll also be supplying the slides from today to everybody, and the recording will also be available, and it was up on Facebook Live as well. Denny, I see your hand.
Thanks, Andrew, and thank you for the presenter's wonderful presentation. I just wanted to revisit that last point that Dr. Christine Oliver had about further investigating the exposures with McIntyre powder as well and how that relates to the current issue. Do you know what the current progress that is? How far you guys are?
Chris, you're on mute.
I do not. I'm not sure right now.
There was some preliminary results reported by the OCRC, the Occupational Cancer Research Center. But yes, they were preliminary, and yeah, we're all very interested to see more of those results to come forward in the near future.
Yeah, very interested. Thank you.
We are 1 minute past, so I don't want to hold up people, but we can stay on for a couple of minutes if there is questions. If not, we'll wrap things up. But the full
We have a question in the chat, Andrew.
Okay.
Will the OCOW OMED tool be added to the OCOW website to be searchable by the public? That's from Lawrence Kurtz.
I think that idea has been tossed around, but I don't know, Paul, I don't know if you are aware of any other conversations about that.
Not at this point that I'm aware of, because OCRC, as I say, were the originators of OMED, and they've shared it with us, and I believe they recently started sharing it with WSIB as well. How wide that goes, or it's really up to OCRC. It's not. I don't think it's up to us to decide to share it. So.
Yeah, that's right.
And one of the things that we're also doing is, as say Martin and OCOW has been developing it for our use. They've got their ways of manipulating the data. So, we're hoping to get together at some point, so to, sort of, compare the approaches and, again, come up with the best way of using this data. So, that's still at an early stage. So to make it a public access kind of database, I can't speak to that, and Victoria Arundel, OCRC, would have a better idea. So that's all I can say at this point.
Hi, it's Kimberly. Sorry, I'm unavailable on video, but I did just want to chime in on that note that we are working at the Occupational Illness Prevention Steering Committee in general, the issue of exposure surveillance data being a big gap in prevention work, and having, redacted data available through, even at a national level, like through the Canadian Worker Exposure Database potentially. And so there is work going on in reducing barriers to that, and really on behalf of all prevention efforts and steering kind of an evidence-based approach to prevention. So just to add that layer in, that is being looked at kind of nationally with the research organizations, with all the provinces, with the OCCIL Illness Prevention Steering Committee, at many levels. So there is hope.
Great. Okay, well, thanks again to all of our speakers and for everybody attending today. And I'd just like to wrap it up and wish everybody a wonderful rest of their day.
Thanks, everybody.
Thanks, Andrew. Thanks, everybody, for coming.
Thanks so much.
Thank you.
Great work, everyone. Have a great day.